This module presents some of the patterning by race in key physical health outcomes, mental health outcomes, and risk factors, and begins to explore the meaning of race with respect to racial disparities in health outcomes. If you look at life expectancy, of course, a major key indicator of the health of a population, you see persistent black-white disparities in life expectancy in 1968 and as well as 2000 that persist today that are remarkably constant over time in the gap between the two races here. And you, of course, see improvement in both, but still a persistent gap in life expectancy in black-white populations overall. You see an even more stark contrast in infant mortality by race when you compare blacks and whites, looking especially acutely in 1968 with a gradual, significant change over 2002, but still a remarkably persistent disparity by race in infant survival. Here, when you make the picture a little bit more complicated, you're looking not only at blacks and whites, but also at other racial ethnic categories, as well as stratification by at least 3 categories of education. And what's so striking about this here is, again, blacks have higher levels of infant mortality relative to whites, as well as to all other racial ethnic groups considered. But you also see a non-surprising gradient in infant mortality by educational attainment. And you see here that the racial disparity is persistent even among levels of those women who have attained a relatively high level of education. So here, even black women with more than 12 years of education have high levels of infant mortality relative to other groups, but also strikingly, they have higher levels of infant mortality relative to other racial ethnic groups with considerably higher levels of educational attainment. So here the racial disparity in infant mortality is clearly not accounted for by differential levels of educational attainment. Looking at specific causes of mortality, you see here again across all racial ethnic groups, the blacks really stand out with higher levels of mortality that persist across time, even in the context of overall improvements for every group between 1980 and 1995. Cancer, in the picture of cancer, things get a little bit more complicated. With respect to incidence, the racial patterning starts to get a little bit more complicated, where you don't see unambiguous racial disparities across time. You do see here that blacks and whites have higher incidence of all cancers relative to other racial ethnic groups. The difference between them is not as stark. There are some points of divergence, but more or less they look fairly similar. But when you then contrast that picture with that looking at cancer mortality, you see then a very stark racial disparity, with blacks experiencing much higher levels of cancer-related mortality relative to whites and other racial ethnic groups. It suggests something about the different mechanisms that might be operating here with respect to the influence of race on health, such that other things might be more relevant in terms of incidence and obscure differential resources, etc., status that might produce racial disparities. Things like delayed childbearing, for example, different patterns of smoking that don't necessarily easily conform to racial patterns in health, might be producing a more complicated picture of incidence. But when it comes to mortality, driven much more by access to care, early detection, the impact of healthcare treatment, then you see something that looks much more like a standard kind of racial disparity picture. Here looking at one specific kind of cancer, breast cancer, and here you have these different components of overall cancer mortality, incidence, and death that are broken out, and you can again see a kind of pattern that's consistent with what kinds of mechanisms might be related to these patterns and to race specifically. So when you look at screening rates, you don't see a lot of differences for blacks and whites. You do see lower screening levels for Asians. Here the picture is not a clear one of racial hierarchy and early diagnosis, but when you start getting into age-adjusted incidence rates, that's where you see that whites really have the highest incidence of cancer. And again, when we look at death rates relative to cancers, despite the fact that African Americans have not been a disproportionate disadvantage up until then. The fact that the mortality rate is so much higher among Blacks here is really stark and really suggestive of some kind of differential access to resource mechanism that's driving these patterns. Switching now to risk factors that might be related to these patterns in mortality and in terms of the patterns of disease outcomes. So smoking, here restricted to boys and men, you see some racial differences stratified by age. What you see is that, in fact, whites have higher prevalence up until a middle age-ish ranges, and then Blacks overtake here this distinction into old age. And this is largely driven here by different rates of terminating smoking rather than differential uptake. Whites are much more likely to initiate smoking at these younger ages relative to Blacks. That's true for boys. It's also very true for girls and women. You really see here there's no point at which Blacks really show higher prevalence of smoking relative to women, white women, in any significant way. In contrast, in diabetes, for both women and men, you see really stark racial disparities that favor whites, much lower prevalence of disparities across all age categories for whites relative to Blacks. Same is true for men. Hypertension, that's also the case here. So cardiovascular risk factors that are not directly behavioral in terms of how they're measured, show much more stark, persistent racial disparities across the life course, also for men. And in the picture of obesity, also somewhat mixed, but in aggregate, you see higher prevalence of obesity among African Americans than relative to whites in several age categories. A little bit unclear with respect to boys and men. For girls and women, the picture is much more stark, where you really see persistent racial gaps in obesity prevalence for Blacks relative to whites. When we come to mental health, the picture is also a little bit more complicated than what would be expected. In the realm of mental health, we have what's often referred to as one of these paradoxes, whereby the health outcomes don't exhibit the same pattern one would expect given expectations about the nature of social disadvantage translating into health disadvantage. Here, the paradox specifically refers to the fact that with respect to some mental disorders, like in the affective disorder realm, things like major depressive disorder, Blacks do not exhibit higher levels and prevalence of major depressive disorder relative to whites, despite the fact that they have higher levels of physical morbidity and mortality, and despite the fact that they have higher levels of exposure to social stressors and disadvantage. We expect, therefore, Blacks to have higher levels of mental disorders like depression, because we know there's a lot of comorbidity between physical morbidity and mental disorders like depression. We also know or assume, based on our prevailing models, the social stress, sort of social disadvantage model, we assume that greater exposure to social stress and stressors will put people at higher risk for outcomes like major depression. So the fact that Blacks do not exhibit higher levels of major depression suggests a paradox. Not only do Blacks not exhibit higher levels of depression relative to whites, they actually show in most population-based studies lower levels relative to whites. The interesting twist on this so-called depression paradox with respect to Blacks and whites is that pattern, the paradoxical pattern, does not hold for things like psychological distress, which is often assumed to pattern similarly to depression. It's also not true for other major mental disorders like schizophrenia. So here you see that in each of these population-based health surveys, Blacks show not only comparable levels to whites of major depressive disorder, but lower levels. If the level of depression shown here by Blacks in these studies was similar to that of whites, it would still qualify as a paradox. It would still be paradoxical in that it would be inconsistent with our expectations. But what's more striking is, in fact, the prevalence of major depressive disorder is even lower among Blacks relative to whites across all of these studies. The differential patterning in health outcomes, these racial disparities in health, have of course generated a lot of interest in and research regarding what it is about race that produces these differential health outcomes. And the first obvious question to be dealt with is this a biological phenomenon? And the problematizing of race as a biological construct has been a subject of a lot of debate and literature over quite a long period of time. And I think it's quite established in mainstream social sciences that the differences between racial groups reflect more social differences rather than innate biological differences. And put succinctly by several scientists, the idea that the finding that there's actually more genetic variability within human racial groups than between them. And so race itself is not a good proxy for genetic variability across racial groups. Phenotypic characteristics are not a good way of reliably predicting the genetic makeup of subgroups of the human population. And while this has been well established scientifically and well accepted in a lot of mainstream social science circles, it's still the potential underlying racial genetic basis of race is still an ongoing issue that periodically resurfaces in biological sciences and in public health, sort of requiring ongoing attention to what race means, what it stands in for, and what the implications for health of race-based, race-associated biological characteristics. If we start from the premise and accept the idea that race is primarily and most meaningfully a social construct, then the one retort to that is, of course, well, if race, like gender, has no reality apart from some social construction that would be group-specific, time-specific, that would be largely a human production, then what does it mean? The answer to that is, of course, that the social meaning of race is very, very real and significant. And even if something is socially recognized, socially assigned, it still is, and in fact is hugely impactful in terms of the lived experience of individuals, and therefore is very, very relevant for understanding what kinds of exposures and resources people have access to and how they might impact their health. Moving beyond putative potential genetic differences, explaining racial disparities in health, another obvious target is whether these patterns reflect something that is more about differential diagnosis or differential reporting of symptoms. Differential diagnosis might be particularly relevant if the health outcomes reflect racial differences in the receipt of a diagnosis from a healthcare provider. So if you're looking at surveillance data and it reflects racial differences could, in theory, reflect the fact that certain groups are less likely to receive access to care, or in a care setting be differentially likely to receive a specific diagnosis, reflecting bias in the diagnostic process in a clinical setting. That explanation, while very, very potentially relevant in some instances, is not sufficient to explain the observed differences in health outcomes by race based on population-based health surveys. There, you might be looking at differential interpretation of or willingness to report symptoms that are elicited on population health surveys. So if some groups are more likely to label symptoms or experience symptoms differently than others and be more or less willing to report these symptoms in a survey interview context, you might see racial differences emerge that are attributable not to real differences in underlying health conditions, but to differential reporting. This is a hypothesis that might be particularly relevant to certain health outcomes, certain mental health outcomes, where there's a lot more subjectivity relevant to the description of symptoms presented. And in some cases is still, I think, an open question with respect to some health outcomes. It might also be that you see an intersection of these two processes, health surveys that elicit questions like, have you ever received a diagnosis from a health provider? They assume comparable access across groups and access to health services, and therefore the ability to receive the diagnosis in the first place. So even if you're not looking at provider-generated records of health diagnoses and you're relying on participants' reporting of the diagnosis itself, if there's differential utility of healthcare, access to healthcare, or differential diagnostics happening in a healthcare setting, you might still capture that in a health survey. The differential interpretation of a willingness to report symptoms interpretation is less convincing when it comes to more objective related health outcomes. It's also potentially problematic in that if it's used reflexively without a real understanding of group differences in these patterns can reflect cultural stereotypes or reification of cultural tropes that are more about stereotypes than they are about scientifically generated understandings of group differences. If we dispense with these two possible mechanisms that could explain racial differences, that related to biology, to genetics, and culture, which is, I think, a big open question to some extent. There may be a lot of potential benefit of further exploration, but this is largely unexplored empirically. We come to the other two interpretations of racial differences in health that have received quite a considerable amount of attention, and that is whether these differences are attributable to socioeconomic differences. That would be, of course, relevant to the access to care question, but whether, and simply independent of that, you're observing health outcomes whereby race is really a proxy for differential access to resources, and or the role of racism and discrimination as direct, meaningful social experiences that might produce different health statuses, not just access to diagnoses, but actual differences in health outcomes. The fact that race is, in essence, then standing in for these other potential real exposures and mechanisms by which race translates into health raises questions about the construct validity and the utility of using race in both epidemiologic and social surveillance research. And this is something that's been debated in past times. It's been discussed with respect to even routine data collection on census forms and so forth. And I think this is a very large debate. It's an important debate to continue having. And I think that the most important take-home messages from this debate are that as long as race has a significant social meaning and is an important driver of and proxy for social experience, we need to continue to incorporate race into our data collection, to monitor progress, and to try to understand the implications of racialized social experience, but at the same time increasingly develop different and better ways of capturing the exposure, specific exposure of interest, rather than simply using race as a proxy for it. Another argument that has been raised in epidemiology circles is the idea that race should not be a variable in epi research because there's no counterfactual. There's no way to take an individual of one race and manipulate that exposure such that they could have a different race and then look at the independent effect of race. I have a little patience with these arguments because I feel like it treats race as indeed the exposure of interest rather than a proxy for social exposure. And in theory, the social meaning of race and the social exposures that travel with it could in essence be modified and manipulated such that we could change the meaning of, in a particular social context, being black versus white, and therefore understand the differences in how that racial identification of individuals translates into certain kinds of social experiences with meaning for health outcomes.